Hello, good morning, everyone, and welcome to this GreenNet Europe session. After the opening keynote forum this morning, this is our first live session of this year conference. And before I give the floor to the sponsors of this conference, Innovative Approaches to Sustainable Healthcare Delivery, I would like to share with the audience some housekeeping. So first of all, please add this. You can do this by clicking on the icon with a small calendar and a plus. You can also send questions via the chat of Swapcard in the panel to the right of. We will be collecting these questions at the end of the session and putting them to the speakers. Please feel free also to connect with the speaker by looking for the speakers in the platform. And please note that this session is being recorded and it will be available after the session has ended. And now I'm very pleased to introduce Christina Zikan, who is representing Alcon. They are the sponsors of this session, and I would like also to take the opportunity to share to say a big thank you to the sponsors, because without sponsors, GreenNet Europe would not be possible. So thank you, Christina, and I give the floor to you. Thank you.
Thank you, Maria. I'm really delighted to be here representing Alcon for this session. My name is Christina Zikan, and I head up Market Access, Government Affairs, and Tendering for Alcon Surgical in Europe. Alcon's mission is to help people see brilliantly. Now, we started 70 years ago in a small pharmacy in Fort Worth, Texas, but today we are the global leader in eye care. Every year, our vision care and surgical products touch the lives of more than 260 million people living with eye conditions such as cataract, glaucoma, retinal disease, or refractive errors. And our innovation helps improve their quality of vision as well as their quality of life. So if we talk about the planet, now we believe the planet is definitely worth seeing, and that is why Alcon has embarked on a journey for a sustainable future. We've put in place a number of robust programs to enable a continuous improvement in terms of environmental footprint and performance of our products. So to give you just a couple of very recent examples in the space of packaging and waste management, for example, when we talk about our intraocular lenses, which are used for cataract surgery, we've been able to reduce the packaging weight of these IOLs by more than 50%. By reducing the directions for use brochure from the packaging and replacing it wherever possible with an online version. And in another example, for another important surgical product, we've optimized the packaging and the composition of the product to reduce the associated operating room waste by more than 80%. So as a supplier, we look at waste reduction, water stewardship, and energy efficiency in particular. But we also believe that it's absolutely critical to partner with healthcare providers for innovative solutions to reduce the carbon footprint across the entire treatment pathway without compromising patient safety. Now, to illustrate this partnership, Alcon is proud to sponsor this particular session, where we'll also hear from Newcastle about their environmental program and how we're working together for sustainable cataract care. Thank you very much.
Thank you so much, Christina, for this introduction. And now I'm very pleased to move on and introduce the panel of our speakers today. So I think I forgot to mention my name. My name is Mireia Figueras, and I'm Climate Officer at Healthcare Without Harm Europe, and I will be moderating the session today. We have a panel of 5 speakers. Today, I'm very pleased to introduce Annalisa Mills, Sustainability Manager at Newcastle upon Tyne Hospital's NHS Foundation Trust. We are also joined by Dr. Michaela Grottenfeldt-Enagrim today, who is researcher at University of Helsinki. Today, we also have with us Dr. Francis Mortimer, medical doctor from the Center for Sustainable Healthcare. And oops, sorry for this. And we also have with us Dr. Heather Bates, Principal Lecturer at School of Sports and Health Sciences at University of Brighton, as well as Dr. Sarah Walpole, Clinical Fellow, Associate Clinical Lecturer at the Newcastle upon Tyne Hospitals NHS Foundation Trust at Newcastle University. This is our panel of speakers today. And again, I remind the audience that you can be adding your questions in the chat. We will take them at the end. And now I'm very pleased to give the floor to Annalisa Mills, who will be presenting low carbon care at Newcastle Hospitals. Annalisa, the floor is yours. You can now share your screen.
Hi, can you see?
Yes, we can see your slides. Annalisa, we cannot hear you. I'm not sure if you are muted. Okay, now. Annalisa, can you hear me?
Yes, I can hear you. Can you not hear me?
Yeah, we can hear. We can hear you, and we can see your screen as well. Yeah, the floor is yours.
Thank you.
No worries.
Okay, so well, thank you very much for the opportunity to present and for that introduction from Alcon. And Alcon will feature as part of our presentation about the work that we're doing at Newcastle Hospitals. So the outline for this short session is just to start by looking at our wider climate emergency strategy that we have set at Newcastle upon Tyne Hospitals, and then pick one theme from our strategy, which is our low carbon care pathways theme. And from that theme, I've picked out 5 examples. Obviously, we'll just be able to touch on each of those, but hopefully in the chat box, hopefully the link to our climate emergency strategy document will be shared so that you can access that, and I'll share my details at the end if anybody has any questions and they want to contact me. But starting with the first bullet point, our climate emergency strategy. At Newcastle Hospitals, we're seen as, we were the first organisation in the healthcare sector to declare a climate emergency, with the statement that the climate emergency is, in fact, a health emergency. So that's thanks to the leadership from Dame Jackie Daniel, our CEO, and also James Dixon in the top right photograph there, who is our Associate Director for Sustainability, who's led the charge at Newcastle. We also have a breakthrough objective to embed sustainability into our culture, and we have a Shine brand, which is sustainable healthcare in Newcastle. We're in a very fortunate position with the full support of our CEO, Dame Jackie Daniel, who's been very involved in the sustainability agenda, both within the UK and Europe-wide as well. And just one of the statements from our most recent annual report from Dame Jackie is that NHS trusts can use our influence to decarbonise not just our buildings and vehicles, but also care pathways, medicines, and our wider supply chain, which I suppose is what I'm going to look at in this session. So this is a screenshot of our climate emergency strategy. Hopefully, as I say, the link, you'll be able to access that. Can't quite see the chat box at the same time, but hopefully it's been shared. You'll see we have a vision to be a global leader in sustainable healthcare delivery, and that includes through collaboration and innovation. So often that is working with partners to pilot and test innovative solutions here at Newcastle, with the view of helping our patients and communities to thrive within the means of our planet. We have 3 overarching goals in the area of zero carbon care, clean air, and zero waste. We span action across 8 different themes. So we have a full 5-year action plan, which includes action in the areas of energy, water, waste, buildings and land, journeys, procurement, care, and people. Obviously, there's a bit of overlap and interface between these themes, but I'm going to focus on the care one with a bit of look at procurement and people as well. In our annual report, you will see our progress and what we have achieved over the years. So, for instance, if you can see down at the bottom here, 23% reduction in anaesthetic gas emissions, achieved in one year. So we'll be having a look at this, a 5% reduction in our direct emissions. So but if we look at the bigger picture, which I'll just move on to, so this is our carbon footprint. So we measure across all of the scopes of the Greenhouse Gas Protocol following the NHS Net Zero Plan framework for measuring and reporting our footprint. And you can see how that's broken down here, with anaesthetic gases making up 2% of the footprint as an example. But what you'll see is that the supply chain emissions make up the biggest part. So this pie chart here is another way of representing the data that was in the table. So our direct footprint that we have control over, our building energy, is 22%. We also have control over anaesthetic gases, fleet, waste and water. And the footprint that we can influence, patient and visitor travel, staff commute, but also the blue section is our procurement. You can see that is the biggest proportion of our overall impact. And looking at our performance against our base year, as mentioned, we've seen a 23% reduction in the carbon footprint from anaesthetic gases, which is shown in these graphs here. You can see the different gases here: desflurane, isoflurane, sulfurane, nitrous oxide, and NOx here. You can see those have reduced. Now, some of that will be down to the pandemic and the reduction in elective treatment. However, we also believe a significant percentage of that is due to changes in clinician activity as well. So we've seen a 50% reduction in the use of desflurane, which is the most damaging of all of the volatile anaesthetic gases, and a 30% decrease in the total carbon footprint from inhaler prescribed. However, our overall carbon footprint performance, our direct footprint has reduced slightly, around about a 5% reduction there. But looking at our full carbon footprint, our footprint plus, unfortunately, it is going in the wrong direction in that our footprint is still increasing. So even though this is reducing, it's not reducing fast enough. We have a Tyndall approved carbon budget. We're not yet in line with our own ambition. So we know we need to get there further, faster. So picking out one of those 8 themes from our strategy, low carbon care, we have details in the document that's shared with you what we want to achieve by 2025, which includes engage in research and innovation in order to lower our carbon across our care pathways, lead on the systematic reduction of anaesthetic gases, collaborate to reduce our carbon footprint of respiratory care, and empower clinicians to improve sustainability in their models of care, as well as building resilient care services in response to a changing climate. We've got details of how we would achieve that and how we measure it, but I'll just have to glance over that for now. So first of all, the first example, very proud to be able to say that in the UK, the first baby to be born using climate-friendly gas and air, and here's a little picture of baby Rosie. And this is looking at the impact of NOx, which is nitrous oxide, which has a high global warming potential of nearly 300 times carbon dioxide. So we partnered up with Medclaire. They were able to pilot the technology with us at Newcastle. Although it's widely used across Sweden and other parts of Europe, it was the first in the UK. And there's now been, pleased to say, many other births. I noticed Scotland recently as well. So it's great to see that now being put in place. But this collects the exhaled nitrous oxide and cracks it and separates it into nitrogen and oxygen, which are therefore not greenhouse gases. So therefore that's a better environmental outcome, but of course also a better outcome for the staff working directly in the maternity units, because they're not exposed to the same amount of expired gases as well. The second example, very pleased to be able to say that a clinician-led, a collective project of clinicians at our Freeman Hospital in the anaesthetic department have made a move to announce the removal of desflurane to stop using it entirely. So very important to note that this is on the back of years of research and presentations. They've done a deep dive literature review where they could not really demonstrate any patient benefit from desflurane. So on the basis of the additional environmental impact and the additional costs, they couldn't justify that as the source of anaesthetic care. So a group of clinicians have made a proposal to stop using desflurane at our Freeman hospitals. They've also decided to become nitrous oxide free, so they're turning off the piped nitrous oxide manifolds, capping them off, and that will equate to a saving of around about 891 litres of nitrous oxide, which has been converted into 524 kilograms of carbon dioxide, or £20,000 a year, approximately, those savings from not having the leakage and the use of that nitrous oxide. So there will be portable Entonox still available, and the residual stocks are going to be sent to our other hospital, the RVI, where piped nitrous and desflurane will still be used in the foreseeable. Now, we have got additional plans for the year ahead. I won't go into these in detail, but they're all in our our SHINE report. And I wanted to flag that if you do want to know more about this, definitely, if you can book in for the conference, for the presentation for Dr. Chris Allen, which is tomorrow, you'll see him here. You'll hear more detail about that project, as well as if you want to listen later on, Dr. Sarah Walpole will be talking about the impact of the inhaler project that has been she's been leading and implementing at Newcastle. So just quickly, another couple of examples before I finish up across the care pathway. We've also been developing tools and support. So this is a screenshot from our intranet, and all of our clinicians and all of our staff, whatever role they're in, can access a range of support tools. So for instance, we've developed some training, which is actually open to internal staff, but also external staff. So anybody in the healthcare setting can attend a course run at Newcastle Hospitals. We're now an IEMA approved training centre, which is the Institute of Environmental Management and Assessment. So we're looking to skill up our workforce, and we're getting actually, the courses are booking out. The interest is really high, which is really encouraging. We've also developed a range of resources following our Newcastle improvement model to help run sustainability projects in a care setting in different departments, and a range of resources to support staff as well. So an example here is that we've developed a model directorate. So we have a couple of directorates already following this framework, where they've appointed a sustainability ambassador who is an agent for change within that department, and they're looking at training for managers, Green Champion Plus and Green Champions. So we've got a range of tools available to support people in all of these roles. And one example here is our Newcastle improvement approach, where we've built a framework for members of staff to drive quality improvement projects that bring a sustainability benefit within the workplace. So the last couple of examples, example 4, the Alcon project is still ongoing here at Newcastle, but building on a benchmark study that was completed in 2013, which looked at the carbon emissions of a typical cataract surgery. It found that one example typical surgery would equate to around about 181 kilograms of carbon dioxide equivalent. And when that's broken down, you can see the biggest proportion, again, being procurement, building energy, also a big part, as well as travel. So what we've looked to do is Alcon are working with us they're leading this project to replicate this process and this study here at Newcastle. And we have a 3-year plan that they've developed that they're leading on, which is to repeat the clinical study methodology to measure Newcastle Hospital's cataract surgery footprint. And they're following the ISO 14064 standard, and they're also currently undergoing independent verification from NQA against the PAS 2060 verification standard. From there, they'll develop a carbon management plan to implement the recommendations to reduce the impact of cataract surgery. They'll be looking year on year to remeasure that and identify further carbon reduction opportunities. We'll obviously be working in partnership with them to implement those opportunities, and Alcon will be offsetting the remaining amount that can't be eliminated or reduced, in order that Alcon will be able to say that their surgery will be carbon neutral. So that project has been underway for quite some time, and we're getting to the closing stages of that. The final example to touch on in my short space of time is that we're really pleased that last week we won an award in our procurement for a project that was led by our procurement directorate. So looking back at that that model that we developed for directorates to run their own projects. Really pleased to see our procurement team initiate a 5-step process to support suppliers. So as you will have seen on that pie chart, procurement being the biggest part of our footprint supply chain, we're asking our suppliers to follow these 5 steps. Where first of all, they tell us their views via a questionnaire. We've then made a series of webinars available. They were live, but they've now been recorded and are made available for suppliers to watch. Then we're asking them to report their footprint directly to us, and also importantly, to report what their net zero target is and when they aim to get there, and to publish that target and then act to reduce their footprint. So we're pleased to say that over 500 suppliers are currently engaged in this 5-step programme, and we're working our way through those steps. So if anybody has any further questions, that's my contact details up there, but I'll finish for now.
Thank you so much, Annalisa, for this great overview of the low carbon care at Newcastle hospitals. Now it's time to move to the next presentation about sustainable health and well-being at maternity and child health. So I will ask now Micaela to share her screen and turn on her camera.
Hopefully you can steal the screen share from me, because I can't see how to stop sharing mine.
Yeah.
Seems to be working.
Now, yeah, it seems to be working. Yeah.
Okay, so thank you very much, Mireia, for the introduction. I'm very happy to be here today presenting our project in which sustainability thinking has been introduced into the daily encounters at the maternity and child health clinics. The project was coordinated by Physicians for Social Responsibility Finland and funded by the Finnish Ministry of the Environment, as well as the Kestävä Lahti-säätiö, which is the foundation supporting the Green Capital Year of Lahti. The project was conducted in Päijät-Häme region, which is a region in southern Finland, a little more than an hour's drive from Helsinki, and with around 200,000 inhabitants. The biggest city in the region is Lahti, which has been the European Green Capital this year. So indeed, a very fertile environment to be working in. However, I do want to express a special thank you to the leadership in Päijät-Häme, as well as the public health nurses at the clinics with whom we've been working with for their active engagement despite the pandemic and other current challenges within the healthcare sector. My own background also lies within the maternity and child health clinics in Helsinki, so I do know how demanding and challenging it can be to find time for trainings and meetings on top of all other daily work. In addition to this project, I'm also currently working as a researcher in the HUMUS Healthcare for Sustainable Future project at University of Helsinki, of which you can hear more about in a presentation held by my colleague Kristiina Patja on Wednesday. I'm also happy to introduce the rest of the team, a cross-disciplinary team with both doctors as well as sustainability scientists. In addition to the core team, we've also been welcoming inputs from other healthcare professionals as well as environmental scientists during different phases of the project. The project is firmly grounded in sustainability thinking, encompassing both social, economical, as well as environmental aspects of sustainability. And we see that the medical professionals could have a critical role to play in a shift to more sustainable ways of living, both at individual as well as societal levels. We also call for a better understanding of the multifaceted linkages between human health and the well-being of our environment, especially within the healthcare sector. We emphasize that humans are part of nature and that human well-being and health is impossible to achieve without protecting our environment, as in line with planetary health thinking. So as for the setting, the maternity and child health clinics, in Finnish called Neuvola, are a fundamental part of the Finnish public healthcare system, with an uptake of nearly 100% among families. The services are free of charge, and they include comprehensive community-based care covering both health promotion as well as risk screening during pregnancy and early childhood. The services also include family support with attention to relationships and parenting, and they are run by public health nurses with the support of doctors and other health care practitioners, such as nutritionists, psychologists, physiotherapists, as well as social care workers. The Neuvola clinics are traditionally a most trusted source of information during the important stages in life that they tend to. Expectant mothers normally meet with a public health nurse 11 to 15 times during their pregnancy, each visit offering possibilities to discuss healthy lifestyles, in addition to directly pregnancy-related issues. Children visit the child health clinics normally around 16 to 17 times during the first 6 years of life, which is the school age in Finland. And during these visits, their physical, mental, social development is assessed, and parents are supported in providing secure child-focused rearing and care. The clinics also provide vaccinations and healthy lifestyle promotions to the whole families. The guidelines for the services and the health promotion messages to be covered during these visits are all outlined at the national level, however, with some adaptation at the local level. Aspects of sustainability have not previously been mentioned or taken into account in the content description for these care visits. And according to our experience and earlier findings from the Finnish healthcare system, lacking knowledge and prejudice against vegetarian and vegan diets, for instance, is still common among healthcare providers. This, together with other insights regarding the unpreparedness of healthcare providers to meet current needs, especially those expressed by environmentally concerned clients and families, made us realize there was a strong need for updating the Neuvola services. We also realized there could be a huge possibility for supporting other families to shift to more sustainable lifestyles with the right behavioral change messages and an appropriate approach. So we managed to sit down with 6 public health nurses of one small Neuvola in Lahti, working together in participatory workshops, which ensured a safe space for discussion and ideation. Altogether, we conducted 4 workshops with these public health nurses, as well as with families from the Neuvola clinic. After introducing the nurses to sustainability thinking and current environmental challenges, we utilized design as well as future thinking approaches to enable them to recognize and explore their own role in solving the sustainability crisis. The aim was to identify connections between their daily work and environmental protection measures, and to identify different possibilities for concurrent health and sustainability promotion. That is so-called win-win solutions. What we found during the discussion was that families were very much welcoming support regarding sustainability aspects of lifestyle choices. They also expressed a need for support in tackling environmental emotions, and they felt that the Neuvola had not adequately been responding to these needs. Together with the public health nurses, we managed to identify already existing good practices and health promotion messages that also support sustainability. We also found that these messages could be emphasized in the routine daily work to support better uptake of sustainable habits. Sometimes this would require a minor shift in focus or a change of wordings. For instance, instead of asking about children's hobbies, they could talk about what the families like doing together. Or instead of asking about their exercise routines, they could ask about their primary mode of transportation and present walking, biking, or public transport as good ways of increasing the physical activities in daily life. We also noted that many times there is a need to change the way we talk about food and dietary choices to enable plant-based diets to become the new norm. We were delighted to find that the public health nurses welcomed this idea of actively promoting sustainability as part of their routine work, and some even expressed increased job satisfaction through this new opportunity. At the end of the pilot, we identified a need for integrating sustainability thinking into the local guidelines, enabling the active sustainability promotion in the routine work in the Neuvola clinics, and paving the way for a rollout of new practices also to other clinics in the Päijät-Häme region. So our next step was to, again, with the participatory workshop methods and with environment and sustainability experts, as well as public health nurses, and this time also a nutritionist, go through the content of the Neuvola guidelines and integrating sustainability aspects into the care protocols for each visit. We examined what was already there, what messages could be strengthened, and what additional sustainability aspects that could be integrated into the discussions. We also identified new aspects that could be incorporated, and as completely new content, we, for instance, introduced the mentioning of harmful chemicals, as well as the importance of nature connectedness. This, as contact with nature, is associated with numerous psychological, physiological, and social health and well-being benefits, including a source for beneficial microbial exposures. We also talked about how to acknowledge and allow space for different environmental emotions, such as climate anxiety. So already when starting our first pilot in Päijät-Häme, we decided on a few important principles for the work. First of all, the focus should always remain on health and health promotion. Secondly, we wanted to emphasize the recognition of humans being part of nature as an essential part of sustainable health promotion. We also wanted to enable, through this work, we wanted to enable healthcare professionals to increase the possible impact of their work without increasing the workload, as also the well-being of healthcare professionals is certainly affecting any sustainability efforts. And as always, within the Neuvola, the services are client-centered, and the nurses are adapting the advice they are giving according to the specific needs and circumstances for each client and each family. We also stressed that it would not be mandatory for Neuvola nurses to actively promote sustainability. However, we wanted to point out that this can be done also without mentioning either climate or environment, and that preventative medicine in itself is already supporting sustainability efforts, as could also be heard in Julian Engelen's presentation this morning. So when going through the content of the Neuvola visits, we identified 5 cross-cutting themes that were relevant at more or less every visit. These were healthy and sustainable dietary choices, including the promotion of plant-based diets, active transport and movement as part of daily routines, connections to natural environments and nature connectedness. And we also wanted to include consumer choices as a question that could be mentioned during Neuvola visits, depending on what subjects were brought up by the clients. So these could include discussions about the use of diapers, cleaning products, clothes or toys, or whatnot. We also wanted to emphasize mindfulness and stress management as the most important basis for a sustainable life. focusing the attention on the small sources of joy in life. And lastly, but not least, we found a need to underline the importance of interactions, which includes both the interaction between nature and human health and well-being, but also the interactions between people and between healthcare providers and their clients when discussing these issues. To support the Neuvola nurses to remember these themes and the new content in the guidelines, we developed this memory aid, which also illustrates the possible impact of their work. We were able to roll out the new guidelines in all of the Neuvolas in Päijät-Häme region this fall. And after the training, we gathered some feedback from the nurses. And we're very happy to find that a vast majority of the nurses found the trainings either useful or most useful. And that after our trainings, 93% of the participants found that the sustainability should be actively promoted in healthcare. However, I need to point out that although this training was offered to all of the 70 Neuvola nurses in the Päijät-Häme region, only 29 of them participated. Many were unable to participate due to time constraints and other factors, but we do think that also some might have chosen not to attend, being more skeptical to this new way of thinking. And I would like to end with some take-home messages, which would be that we truly think there is an opportunity to promote sustainable lifestyles within the healthcare setting. However, nobody can solve the sustainability crisis on their own, but cross-disciplinary work can be most essential in finding well-working solutions. And that new guidelines and accompanying trainings can enable the active engagement from healthcare practitioners and helping them take on a new role as change agents. And ending my presentation with our slogan, when protecting the environment, we also protect our own health and well-being. And I'm happy to share that less than 2 years from the planning phase of our project, we are now actually having discussions with the Finnish Institute for Health and Welfare about how to include this new thinking and new content into the national guidelines. So just wanted to state that although at the start the needed changes might feel impossible to achieve, many times it can be possible to reach them far faster than we would ever have thought. Thank you very much. And here is my contact details for anyone wanting to address me directly. Thank you.
Thanks so much, Michaela, for this presentation and for finishing it with such an inspiring way. We have now our next presentation about sustainable kidney care by Dr. Frances Mortimer. So Frances, the floor is yours, and you can now share your screen and turn your camera on.
Thank you very much. Yes, I'd like to tell you about sustainable kidney care. My name's Frances Mortimer. I'm the medical director at the Centre for Sustainable Healthcare in Oxford in the UK. And we've been working for 12 or 13 years now on sustainability in healthcare. And actually, the work in kidney care is some of the first work that we did. And it's through that work that we developed our sustainable specialties approach and model, which I'm going to tell you about. But the reason that I'm talking about it today is because in the last year, there's been a lot of reactivation of that work, and then we're now building on those foundations and taking those forward, and we'd be keen to make connections across Europe for sustainable kidney care. So back in 2009 and 11, we had some managed to get funding for some fellowship posts, and we were able to appoint first Andy Connor and then Tara College, who were trainees in kidney medicine as Green Nephrology Fellows. And this is a diagram of the sustainable specialties model that we developed together with them, really. So you can see the fellow is a very important person. That's why they're big, and that's because they have the time to help develop the work. And that's often been the limiting factor in lots of sustainable healthcare work. So if you can create time, and also that person needs to be from that specialty. They don't have to be a doctor, but they need to be somebody who is already understands that community and part of that community. And then they are able to coordinate, and they work together with us, and I worked very closely with them to do the other elements of the work, which is, first of all, to create a network of champions or people who are taking action in their own setting and sharing the learning that they're having from that. So one of the first things we wanted to do was to survey kidney units across the UK to find out what certain things about what they would, how they were using energy, travel, and using equipment and so forth to understand sustainability. And in order to do that, we realized we needed a friend inside those units, and that's how we created this network of champions. We asked the directors of all the kidney units to identify somebody, and these people became the starting point for our green nephrology network, and they were an enormous and important resource for trying things out and sharing with us what worked and helping us to study some of their examples. And we supported that through things like conferences and awards, and also developing a resource library with case studies and an online networking space, which I'll share with you later in the talk. So just a few examples of some of the practical changes that we studied with them. So one of the first ones was looking at the saving of reject water, which is the water that is turned away by the water purification system, the RO unit in the dialysis unit, hemodialysis unit. Quite a lot of water gets rejected, but it's good quality water, so you can actually use it for other things. You could use it for flushing the toilets, but you can also use it for sterilization services or laundry and other things. And we showed that they were able to save a lot of money. So depending whether you were doing a retrofit, which means you're putting in the tanks and things after the unit's already there, or if you build in the pipes at the beginning when you're creating a new unit, then the cost can be much less. But either way, you're still saving a lot of money year on year. And you're saving a lot of water and carbon emissions as well. Another early example was, of course, people they see a lot of waste in dialysis. There's a lot of plastic, single-use plastic used, and paper packaging and that kind of thing. So there were, and there's also the opportunity to put less waste into the incineration pathway, and instead put it into domestic waste. So there were projects that showed those changes and were able to save money and carbon. One of the kidney units did a whole range of changes at once. So changed the booking of ambulance journeys or sort of patient transport for dialysis unit to group people who live close to each other, or group the times of their treatments so that you could have a more logical transport route. They managed to reduce a lot of food waste by introducing a sandwich menu. They encouraged people to bring in blankets from home that they would wear during dialysis, so that they didn't need to have a laundered blanket each time from the hospital. And they changed the size and the packaging for the cartridges of bicarbonate, which is one of the ingredients needed to create the dialysis fluid. But stepping back a little bit more from the logistics of giving dialysis, back in those days, there were not as many telephone clinics as there are now since COVID. And one of the reasons is because it just wasn't seen as something that maybe patients wanted. And also there wasn't a very good payment mechanism for the hospital. If you have the patient come and see you, you get paid a lot more for that from the government versus if you have a telephone call with them. So it was really important to show that this model was actually working very well, that patients who, post-transplant patients who have often to travel a lot and have to take a lot of time out of their daily lives to attend healthcare appointments, were actually very much in favour of doing some of those appointments over the telephone, and that it does save carbon. And if you can work out the money side, then it could save money as well. And even better than that, of substituting some of those trips, is actually, if you can change the patient pathway, then you might not need appointments for some people in secondary care altogether. So if you can provide better communication between the GP, the primary care team, and the specialist care so that they can get advice, then you may not need to transfer that patient's care to the kidney doctors. You could keep supporting them in primary care with guidance on good management. And this is one of the case studies showed how facilitating that process with the electronic system could work effectively. And we estimated that that would save, obviously, carbon emissions from avoiding outpatient visits. So those are some examples of the learning that was happening on the ground in different places, and we helped to bring out those lessons and share them with the rest of the network. The other thing that the fellow is able to do is to do some research. So if we understand better about where the environmental impacts are coming from in kidney care, then we know how to target our energies, and we can produce tools and information that will support these people to be more effective. So some of the work that we did was looking at the carbon footprint, first of all, of a local renal service in one place in the United Kingdom, to understand the different elements. It shows a similar picture to healthcare overall in the UK, in that the biggest part is from procurement, but actually this 72% was even higher than for other branches of healthcare, and the waste disposal is also a bit higher than other branches of healthcare, and that is, we think, due to the use of single-use equipment in dialysis. Because if you look at this breakdown here, it shows that despite the numbers of patients who are having dialysis, hemodialysis or peritoneal dialysis were actually quite small compared to the overall numbers of patients with kidney disease, the carbon footprint of their care makes up for the 2/3 of the whole. So there's definitely a hotspot carbon emissions from dialysis. And you can see here, so that waste disposal and clinical supplies and pharmaceuticals, which include those salts and things that are used to make dialysis fluid, they make up a greater proportion than in other branches of healthcare because of their use in dialysis. We also wanted to understand the difference between different ways of providing care. So we compared home dialysis with dialysis given in centre in the hospital, and we thought because there's less travel, maybe it'd be greener at home. And this graph, so this is the in-centre or in-hospital dialysis, and it shows that actually, although the travel is less for patients, so I think you can see this yellow bit as the patient travel is less. Overall, carbon footprint may not be less from delivering the care at home, because you might be having longer dialysis sessions. And the other thing is you can have the opportunity, which is a good thing for patient care, but you can have the opportunity to dialyze more frequently in a slower mode of dialysis, which uses, of course, more equipment and more energy. But there are different home dialysis technologies available which mean that it is possible to deliver home dialysis at a lower carbon footprint if we adopt those systems. So we know that we need to work together with suppliers to develop the lower impact technologies overall, and that's the subject of a project that is going on at the moment in Newcastle also, like some of the other examples in the session, working with a range of suppliers, and have created a working model of the carbon footprint of dialysis, which will allow us to model the changes from changing different elements of the pathway. And there's also an opportunity to sort of challenge the suppliers to design a green version overall of their technology. And then just rounding up, the other major element on our model is this ring around the outside, which is about creating the context in which all of these people are working, which gives them permission to think about sustainability, which gives them support, that creates the structures, whether that's a payment structure or policy or education that supports them to introduce sustainability into their work and into the running of their unit. We had a really influential program board with with senior people from kidney care in the UK. One of them was the National Clinical Director for Kidney Care, Dr. Donal O'Donoghue, who was a fantastic champion, used to take the message around when he went to give talks and invite us to contribute to different national policy initiatives. Donal's very sadly passed away earlier this year of COVID, but there is similarly very senior support across the UK for the sustainable kidney care work that's going on now. One of the things that Donal helped us to do is to position sustainability as part of quality in healthcare, and that's been really important for making it less about estates and equipment, and include it in thinking about clinical care and how we improve that. And in order to do that, we use these principles of prevention, self-care, lean pathways, low carbon alternatives, and operational resource use. And there are lots of examples of how, by using this framework, we can over time converge on a more sustainable system. And if anybody would like to help and resources in integrating sustainability and those principles into quality improvement or healthcare improvement work that they're doing, please do look up the SUSQI website, which has a lot of resources for that. So what's happening in 2021 is that the UK Kidney Association, together with CSH, where I am, and the Sustainable Healthcare Coalition, which is a membership organisation for companies that want to work on sustainable healthcare. So in a partnership, we've created a committee. It's got 3 work streams. One is about building the network, action, learning and education. The second one is innovation and procurement. And the third one, which is creating the standards and metrics. So we're working currently on reporting measures for dialysis units to show where they are up to on sustainability, and using that to drive change in the future. If anybody would like to connect with our work or contribute examples from your setting or ask questions or anything like that, please do look up our Sustainable Kidney Care online network and join and get involved. And this is the Sustainable Specialties Programme at Centre for Sustainable Healthcare. And I've mentioned also sustainability and quality improvement and our resources, but we have a number of other programmes that we and of work that we do. And so do look us up and get involved in any of those as well, if you would like. Including in our courses, which are open to people wherever you are. So do have a look at those. Thank you very much.
Thanks so much, Francis. And just a reminder to the audience to keep writing your questions in the chat box using the specific chat for questions, the specific tab, sorry. Thank you, Francis. And now it's time to move to the presentation from Dr. Heather Bates about Green ICU. Heather, are you ready?
Yes, can you hear me?
Yes.
And can you see my slides?
Yeah, we see it, perfect.
Great, thank you. So this presentation will be focusing in on intensive care. And my name is Heather Baid. I work as a principal lecturer at the University of Brighton. I'm an intensive care nurse by background, and I lead the intensive care nursing course and the BSc clinical practice course, but I'm also the School of Sport and Health Sciences Sustainability Special Interest Group leader. And I've set up this Green ICU research collaboration to explore how we can be greener in intensive care settings. I've put my contact details there, and if you do Twitter, want to follow me on Twitter, I tend to tweet a fair amount on sustainability topics. Just to say that the Green ICU research project was partly funded by the University of Brighton Rising Stars Award, and I have no other conflicts of interest. So the aims for today then are to introduce this research collaboration that we've set up, to review what's already known about environmental sustainability in intensive care, and just to signpost and explore some of the current and future research and education projects that we're working on to reduce the environmental footprint of intensive care units. And if you are tweeting, we've been starting to use this hashtag sustainable critical care. So anybody from ICU backgrounds, whether it's intensive care or critical care, commonly used phrases for settings in the hospital where very critically ill patients go, then please do use that tweet so we can connect up with each other. So the Green ICU collaboration is a multidisciplinary group that has come together, and I think showing a lot of the themes that have been presenting this morning about how this all takes teamwork. If we're working in silos with sustainability, then that's much more difficult and we aren't going to be as effective. So we've come together as a group of university academics, researchers, scientists, clinicians, and we have a service user on the group, which is a former ICU patient, mainly from the UK. Two of the nurses are from Sweden, and one of the nurses is partly based in Greece as well as England. You'll see Chris Allen there. From those of you from Newcastle will recognize him. Feels like Newcastle's been a theme throughout this morning as well, a real hotbed of sustainability work. And we've also been very fortunate to have contributions and collaboration through consultation with both Frances, who's just presented from the Centre for Sustainable Healthcare, and her colleague Inga Steinbeck. And we set this up as a multidisciplinary group to develop evidence-based guidance for reducing on environmental footprint of intensive care practice. But I would really encourage anybody from wherever you are in healthcare to look around you, if you're in a university setting, looking to hospital or community colleagues from different types of disciplines, including infection prevention, procurement, waste management. But most universities will have multiple different departments. And I certainly found from looking around my own institution that I've been working at in 2007, that there was other researchers out there who were doing work that very much aligned with sustainable healthcare, but they didn't have the healthcare experience, or they're very focused on quantitative research methods and didn't have qualitative research methods that some of the nurses in the group have experience in. So you can see that word cloud there of all of the different themes that are represented within our research collaboration. We've been slightly delayed, or very much delayed, from the pandemic. We set up literally the early part of 2020, which wasn't the most ideal time to start off on this journey because of the COVID pandemic. But I think this, bringing together of people from different disciplines and different backgrounds, whether it's energy, material science, quality improvement, human factors, etc., has been a really exciting start to our journey. And I'm going to signpost some of our early work that we've started on. And one of the things that we're currently just finishing up and hope to publish soon is a systematic review, looking at what is the range of environmentally sustainable practices undertaken in intensive care settings. We've published the protocol in Prospero. So if you wanted further information about the methodology and the methods of the literature review, you can check that out on the Prospero website. And we've done a very extensive search, getting support from a librarian as well, because we found it really difficult to find primary research studies that are really focused on environmental sustainability in intensive care units. As I said, we will be publishing that fairly soon. And for today, I've just picked out some of the publications that I thought might be of interest that are focused on intensive care, but certainly have some transferable themes to all aspects of healthcare practice. This particular carbon footprinting publication by McCain et al. In 2018 looked at septic shock patients in intensive care units and was a life cycle assessment focusing on energy, machines, consumables, and waste. And they compared 10 patients with septic shock in the US with 10 patients in Australia. And what was interesting to note, coming from a UK perspective, was the difference in energy use. And you can see in the States, primarily relying on coal, as well in the Australia. And the energy levels overall came out relatively high as a very significant proportion of the carbon footprint of intensive care units. I also noticed in the publication the reference to air conditioning units, which might be very different in different countries. And this publication did demonstrate that intensive care units are proportionately high in energy and single-use items when looking at overall hospital carbon footprint. Just picking out a few other publications by McCain et al., who really is a leading researcher in this area of sustainability in ICU. This one is a life cycle assessment of central venous catheter insertion kits, which is basically a big fancy intravenous, and the kit that is involved in inserting that type of intravenous. And interestingly, these kits were less expensive, so financially we're better off by using reusable packaging. However, the environmental costs of the reusable kit was considerably greater than those using the single-use kit. And this life cycle assessment really was an eye-opener to our group around not making assumptions and looking at where does energy come from. And if we are reusing devices, what are the energy implications, what's the water implications, what are the cleaning implications, etc. So that's certainly something that we would like to explore further. And this is a life cycle assessment by Sherman et al. In America, I believe, around laryngoscopes, which also would be used in theatre settings, and found that reusable options presented a considerable cost advantage, but were also a better advantage environmentally. And this case study is published on the Sustainable Healthcare Coalition website. And Francis just mentioned the Sustainable Healthcare Coalition as a organization bringing together different businesses and industries looking at improving their sustainability. And they've focused in on continuous renal replacement therapy. I thought that was interesting in Francis's study on dialysis, in sort of dialysis settings around water. And this particular type of renal replacement therapy is a little bit different than what they might use in a dialysis unit, but similar principles. Whether it's dialysis or another phrase we'd use in ICU called hemofiltration. But fundamentally, we're doing a sort of artificial kidney technique. And you can see here that 78% of the carbon footprinting came out proportionately high from the fluids. And we're not able to use the water supplies in the same way. There would be packaged fluids in big bags of fluid and with lots and lots of plastic and lots of packaging involved in that as well. And that's certainly something that anybody in this kind of area would might be interested in terms of what's making up a big carbon footprint within one specific therapy that we do a fair amount in intensive care. And it's very resource intensive. And this survey that was done by 2 medical students in Canada, they had a response rate back from 28% of the ICUs in Canada. And they surveyed the different ICUs, asking them perspectives on sustainability. And initiatives that were already helping were recycling, reducing their stocks, because very commonly in intensive care units, you keep lots and lots of disposable equipment. You sort of have a quota, a list of items that you keep at the bed space. And then every time you turn over and have a new patient come in, you end up throwing out lots of not even clean. There's a lot of them, they're still sterile packages because of, just infection prevention policies and things. And so by reducing how many items you keep right next to the bed space, moving things around, changing their supply carts, their nursing carts, etc. They were found that helped to reduce waste, and looking at changes to how things are ordered, organized and arranged, and donation of unused supplies. And barriers to sustainability were about the lack of buy-in, and not surprisingly, infection prevention policies came up. Within that particular publication, they also had an interesting summary of a case where one ICU looked at how many supplies they were throwing out every single year, just that weren't even opened because of infection prevention policies, and found that worked out to approximately 140 to 170 Canadian dollars per patient. And over the year, that added up substantially to $140,000 or 3,715 kilograms of waste. They did a quality improvement intervention and they made an 80% reduction, which they didn't report in environmental metrics, but in terms of financial savings came out to $110 Canadian. I can't help but think of a nurse. I'm not quite sure what the salary is, but surely you can get more nurses caring for patients for those kind of savings. And if you're interested in recycling in intensive care, I'd recommend these two publications from Australia that have reported on audits specific to recycling programs and improvements that have made around waste recycling, but specific to intensive care. If you had a particular interest in energy, I would recommend this publication by Pollard et al. And it was a bottom-up model predicting electricity consumption within intensive care units. And they included patient types, medical devices, and working practices. And the top electricity usage came out as clinical, because we use a lot of equipment in intensive care, like ventilators, the hemofiltration devices, the monitoring, and that obviously is going to be energy intensive, but also just the physical lighting, the bedside ITs, humidifiers, administrative IT, and television. And my own PhD research was a qualitative study exploring the concept of sustainability within intensive care. And I interviewed people from intensive care backgrounds, asking them their perspective on what did they think were the key things around improving sustainability in intensive care unit. And I used this concept of satisficing. And the word satisficing comes from business, but it was just a way of capturing this idea of, we don't want to lose our quality. We don't want to, by reducing resources, lose quality care. So how do we maintain that quality care, but still suffice within the available resources, whether that's financial, environmental, social? And I think it's interesting in intensive care, particularly during the pandemic, is around how do we define that quality, and the definition of quality care from a doctor versus a nurse versus a physio versus the patient and family can be quite different around priorities. And I think the models that Francis was just showing around prevention and health promotion are very relevant here around starting right from the very beginning, as it was an appropriate admission to intensive care. And certainly during the pandemic, that's never been more pertinent around ensuring that resources are being used responsibly. And then as we do things, traditionally in intensive care, we've done lots and lots of stuff, whether that's investigations every single day, blood tests every single day, lots of sedation, lots of ventilation, lots of renal replacement therapy, but it's not always what's best for the patient and can be very protocolized and very policy driven. So that's one of the things our research group is looking at, is around, where we can maintain quality care, but still suffice within reduced resources for more sustainable practice. And that sustainability stewardship and the idea of responsible resource use, I think, again, has been a theme throughout all the presentations this morning, coming from production and procurement to how we're using them, and where can we reuse, recycle, and recover. And some of the improvements that had been made have now been stopped over the pandemic because of infection prevention practices. And so looking at, how, moving forward, still in the middle of this pandemic, how we can maintain safe clinical practice, but do that in a way that's more financially, environmentally, and socially responsible. This graph has come up today as well. And I think what's interesting, this blue area around medicines, medical equipment, and supply chain, from a clinician's perspective, we're using a lot of that in an intensive care setting, but we're not quite sure what the hotspots are, particularly in the UK. So we're looking at, where can we make the most effectiveness if we are going to be doing projects reducing the carbon footprint of intensive care practice. So the research group, in addition to the literature review, is currently conducting a survey and interviews of people working in intensive care. So if anybody listening in on this call or watching it later on is interested, I've got the website, or you can use the QR code to fill out the survey or volunteer for the interviews. And we're exploring from the perspectives of people working in critical care where they think the most effective interventions can be made for more sustainable practices. And so far, in summary, what we found in the literature review and the initial survey and qualitative interviews that we've done to date very much fit within the themes of the rest of the presentations this morning around reducing, reusing where possible, looking at waste management and single-use items, pharmaceuticals, energy, travel and procurement. And with my education hat on, we are now also introducing these themes into the intensive care nursing education and looking at, in conjunction with the SUSQI framework from the Centre for Sustainable Healthcare, how we can be teaching as well as assessing. I think we actually have been teaching this for some time, but how do we assess this? And, looking at that whole education cycle. I think from an educator's perspective, if you've not yet found the SUSQI framework, I'd really recommend it. And it works really well in terms of both teaching and assessments for encouraging students to be thinking about these principles of sustainable practice and tying them in with the concept of quality improvement. And finally, just to say that Francis mentioned the different networks that the Centre for Sustainable Healthcare have, and we set up this Critical Care SUSNet one. The Intensive Care Society and British Association of Critical Care Nurses in the UK are also looking at supporting this network. And just to be a place where different people from anywhere in the world can come together, share ideas, create posts, ask a question. If you're doing an event, you want to advertise it. So please do join or let your intensive care colleagues know about it so that we can come together and share practices. And thank you very much for your time and this opportunity today.
Thanks so much, Heather. And now it's time to move to the last presentation from this session from Sarah Walpole. So Sarah Walpole will be speaking about sustainable respiratory care. Sarah, the floor is yours, and you can now share your screen and turn your camera on, please.
Thank you very much. Can I check you can see that clearly?
Yes, we can see it. Thank you, Sarah.
Thank you. So my name's Sarah Walpole. I'm a medical registrar based in the northeast of England, and I'm going to talk to you about sustainable respiratory care and some project work we've been doing locally, also in Newcastle. And so thank you very much for inviting me to speak and for all the presentations so far. So there's been a spotlight on anaesthetic gases and metered dose inhalers because they involve the release of gases with global warming potential. And in respiratory care, that's particularly relevant because one type of inhaler, metered dose inhalers, has a much higher carbon emission potential than dry powdered inhalers, which don't use this propellant to drive the delivery of the dose. I think it's important that while that spotlight is there on inhalers, though, in sustainable respiratory care, we consider a much broader picture and that we consider other factors that help us to prevent and to manage respiratory disease, both for individual patients and for populations. So I'm going to talk to you a bit about setting up our project locally in Newcastle, some measurement that we did, some interventions that we've started and like to do, and the best sources of guidelines and resources that I've come across. So I started this project when I became a registrar in Newcastle and wanted to do something that was about clinical sustainability. This seemed like a good place to start, given the focus on respiratory medicine and inhalers. And so I spoke to 3 respiratory consultants and some junior doctor colleagues, and we began to engage others and work out where we could focus. And we thought about this kind of spectrum of different parts of respiratory care that we might improve on to improve sustainability. And we thought about who we could work with. We thought about who has power to change things in this sphere and who might have interest and priority that they can spend on this. So we were able to engage a respiratory pharmacist. A sustainability manager has really supported us with this work. We've had some medical students involved, and we've made some links with primary care, which we felt was really important because any changes made in secondary care could only really have a positive impact if they were supported through primary care as well, although that's a work sort of ongoing and in progress. Thinking about the spectrum of the work, we decided that the place we could have most feasibly act and have most effective impact would be on the inhalers themselves. So making sure inhaler prescriptions were good and correct for the patient, checking inhaler technique, and in thinking about inhaler disposal, which also has significant carbon impacts as well. So we started to trying to collect some data so that we could carry out a baseline data, an intervention, and then measure and see what sort of impacts we might have had. And we thought we'd approached this in 3 ways: by assessing prescribers' knowledge about inhalers, looking at inhaler prescription data for our trust, and then thirdly, doing an audit to see what was happening in terms of patients' use of inhalers. So the prescriber knowledge survey was an online survey. We disseminated it through trust emails. We had over 100 responses, and you can see that about half of them were from junior doctors, which are in green and purple on this slide. And one of the questions we asked them was about their knowledge of the environmental impacts of inhalers. There were 3 questions, so out of 3, the average score was about 1. The consultants in respiratory care were the best at answering this question, and interestingly, other consultants, non-respiratory consultants, had the lowest scores in relation to their knowledge about the environmental impacts of inhalers. And we found a similar pattern in the questions that we asked about the contents of different branded inhalers and the type of devices. So again, it was the respiratory consultants who were the best at this, and junior doctors came next. And just to see the questions we asked about environmental impacts, they were quite sort of 3 basic questions about the footprint of metered dose inhalers compared to dry powdered, about the average amount of doses left in an MDI when it's disposed, which is nearly half according to a survey that's been carried out, and then about the proportion of the NHS carbon footprint that is due to inhalers, which is about 4%. And we also asked respondents whether they felt able to discuss lower carbon inhaler choices with patients. Many said that they felt they would be able to do this, but they would require support and training to do so. So we thought that was a really important piece of learning, that actually we might be able to engage patients if we support prescribers to do that. And some said they've already discussed this with their patients. And then we wrote this up and published this study of prescriber knowledge. So just at this point to say, we then began to work on our patient audit, but we also presented this at a regional meeting. And I think it's worth saying that at this point, we were quite ambitious about what we would be able to do. And this, for obvious reasons, things changed a lot come February 2020. And so we were hoping to really engage a broader group to carry on with our audit, finish it within a couple of months, move on to intervention, and then re-audit within the year. And that didn't quite go to plan. Unfortunately, we weren't able to complete the study of prescribing data just because of the other demands on people's time. But we did carry on with our audit of patients. And I put this slide up to say that it was quite important for us to do pilots of that audit to really get the tool right before we started to implement it. So we were looking both at the practicalities, so how many patients would we be able to survey in a given amount of time, how long would it take to do a survey, things even like realizing that we needed to check whether patients were confused before we tried to ask them questions about their use of inhalers. And then we needed to make sure questions were really clear so that this would be reliable and the questions could just be read out and the audit could be carried out by multiple people in a reliable way. The audit also asked the patient to use their inhaler so we could check their technique and see whether it was good and compare that to how confident they felt with their inhaler. Most patients were on both DPI and an MDI, so we had scales in for different types of inhaler and also for soft mist inhaler, which I haven't mentioned, the other type. And then we had an open question about how they dispose of their inhaler. And using this nice decision aid, which highlights that patients can make decisions about their inhalers if they have preferences about their priorities. We included a question that said, would you change your inhaler depending on these different factors, including sort of ease of use, how you carry it around, and carbon footprint. And again, we've published the sort of trial of this in one hospital, and we're now working with a number of different hospitals around the country to try and carry out a national audit to get a baseline, also to engage clinicians in different centres, and hopefully these individual audits can inform individual patient reviews and benefits for both the patient and sustainability of care. So moving on to interventions, our ambition had really been to get to the point of being able to do active switches where relevant, particularly with patients on both an MDI and a DPI, to enable them to use mainly a DPI. We've actually had to focus more on education and approaches to support more sustainable and appropriate prescribing where possible. So in terms of prescribing, it looks fairly simple when you look at the national guidelines on asthma and how we should prescribe according to a ladder and increasing as a patient's needs increase. For COPD, it's similar. We have some clear guidelines to follow with different classes of inhaler. But when it comes to prescribing, it's actually very complex because of the vast number of different inhalers available. So one intervention which seemed fairly simple but took us quite a long time to develop was a simple poster which just outlines the different inhalers available. It highlights the class that they're in, the type of device that it is, and then in green we have the DPIs which have a lower global warming potential. And we've seen lots of people referring to this as their prescribing because we put it up around the hospital and made it available online. Our guidelines also highlight the importance of checking inhaler technique, and the poster gives information for prescribers about how to do this. Because in reality, many clinicians are not used to checking inhaler technique. So that's not necessarily part of normal practice. And you see we've got pictures of the different inhalers there as well. We also did some lunchtime teaching sessions where we went into some more detail on some of the nuances. So for example, how to choose whether a patient is more suitable for an MDI or a DPI. So whether they can take a steady continuous breath and then they could use a DPI, or if they can't do that, they might be better off with an MDI. And aspects like dexterity might affect their ability to use an inhaler, so that needs to be considered too. In terms of MDIs, it's really important that patients who are on them use a spacer, otherwise it's quite likely that they're not getting an appropriate dose unless they have a really good technique. So when patients do need an MDI, we can reduce the footprint of that and reduce the number of doses they need to take by converting to combination inhalers and using higher dose in one puff as opposed to multiple puffs, and also making sure their technique is right. It's also important we consider wider aspects of care like smoking cessation, sort of any non-pharmacological management, maybe weight loss if relevant, and then consider whether the patient's using their therapy correctly, check they're not using empty inhalers, and ensure that they know about how to dispose of the inhaler after use. And just to say this, all of this work really aligns very well with the Trust's Sustainable Respiratory Care targets, which you've heard Annalisa speak about earlier today. So around clean air, which obviously is beneficial to respiratory health, and disposal side of things being key for our zero waste strategy. So resources that I think are really worth knowing about in this space. From the Centre for Sustainable Health Systems in Canada, there's some infographics. I've used this one already today, and it just shows the global warming potential of different inhalers. They have some information about the implications of this, for example, on recycling and incineration and how many emissions this can save. There's a good website from a UK clinician called Greener Inhaler. It's good for patients and for prescribers. And Right Breathe is a useful website for looking up inhalers to see what device type and what their contents are. And then finally, a couple of guides. This one's endorsed by NHS England and is from Greener Practice, which is a group of clinicians who have developed a table to show low carbon options in each inhaler class. And similarly, Presquip has provided both a guide and a number of online training options for people who want to learn more about respiratory care and how to prescribe appropriately. So in summary, some of the lessons that we've learned during our project, I think we put a lot of time in at the beginning to building our multidisciplinary team, and that was time well spent because it's brought different skills and contributions, and it's meant that despite all the challenges of the last couple of years and despite not getting to where we'd planned to get to, we do have an ongoing group who are interested in engaging in this area, and we've been able to continue parts of the work regardless of those challenges. At the beginning, we really thought about what's feasible and what's effective, where can we best act, and I think that's going to continue to be important. And there are an increasing number of great examples of good practice and guidelines that we can use. So we've still got a long way to go locally and obviously nationally and internationally as well. I think one thing that we noticed from our project was that actually the evaluation itself was a great form of education. We had a lot of positive feedback from people who completed the questionnaire about their learning from doing that and how that might have changed their practice. And I think we really see that as we work forward on this, the agendas of improving patient care and small scale clinical projects can really align with the wider agenda of our organisation. So I just want to acknowledge the local respiratory care team in Newcastle. Thanks for all their contributions and help with slides, and finish there. Thank you.
Thank you so much, Sarah, for the presentation. And now we have still some minutes left for questions. So I will ask all the speakers now to turn your cameras on. And I will start putting some questions to you. So the first one is for Heather. It's from Jonas Bettenboer. And Jonas says, hi, Heather, where did you get the supply chain related data for the GHG calculations of the products from?
So from the, sorry, what was the question again?
Yeah, so Jonas is asking, where did you get the supply chain related data for the GHG calculations of the products?
I'm wondering if that's the one specific to the renal replacement therapy. Are you going to be sharing the slides with everybody, Maria?
Yeah, after the
I will.
Yeah.
So if you look onto the notes section of the slides, everything I've put, because obviously this isn't our own research, this was from our literature review. So in the slide section is from the Sustainable Healthcare Coalition website that reported that particular renal replacement therapy case study. Or if it was the general one, it was from the NHS Net Zero report. And again, the QR code and the slides are there. But the one that was specific to the renal replacement therapy was a Baxter Sustainable Healthcare Coalition that I found. It was openly sourced on the internet, and you can access it freely.
Okay, perfect. Thank you, Heather. Next question is for Annalisa, and it's from Lucy Brooks. And she asked, has the proposal to stop using desflurane at Freeman Hospital been accepted, or are there still anesthetists who are using it?
It's just a very, very recent decision, but it's been a collective decision by the anaesthetic department at the Freeman Hospital to remove desflurane completely. So, so it'll be removed from the Freeman Hospital, and the remaining desflurane is going to be transferred to our other hospital, which is the RVI, and that's happening at the start of next week. So there will be no more desflurane at the Freeman from next week.
Good. Thank you, Annalisa. Next question is for Micaela, and it's from Ana Maria Balino. Hi, Micaela. How did the nurses receive the project considering their already existing workload? And thanks for the awesome support to the Nevola nurses.
Thank you for the question. Yeah, we were actually very surprised by how positively the nurses welcomed the training and this new thinking about including sustainability promotion also in their client visits. So actually over 70% of the nurses plan to include this kind of sustainability promotion in their future healthcare encounters. And they really, many of them also reported more job satisfaction or thought that this would give them more satisfaction in their work. And actually, some of them also commented that they were very relieved of this new new possibilities of taking a stance in these questions and opening up the discussions around these topics, and also giving support to the families, which they have already earlier noticed that there was a need for. So we were very surprised by how positively the welcoming was.
Thank you, Micaela. Next question is for Sarah from Jennifer Young. So, hi, Sarah, did you get any funding for the increased cost of prescribing DPIs over MDIs?
Thank you. So just around the time we were starting this project, there was a piece published that modelled the price of moving wholesale from MDI to DPI. There's an increased cost of switching from MDI salbutamol to DPI salbutamol. But for many of the other inhalers, there's a cost saving. So overall, it should be possible that the switch can be made without increased costs. And I think the other thing to say is that our project, we came to it thinking, let's get these switches done. And as we moved forward, we really started to think more about, actually, let's get people using their inhalers effectively, because obviously a dose of MDI sprayed on the back of someone's throat is not kind of money well spent, and won't be controlling their condition. So ideally, patients should be well controlled and not needing to use salbutamol very much at all. And this should therefore be cost saving in terms of the amount of salbutamol and other inhaled doses used. We didn't get any funding towards this, but should we need some in future, there are possibilities to apply for funding for Greener NHS, I think.
Thank you, Sarah. And this is the last question we will be taking because we are arriving at the end of the session. But Francis, from Peter Lessing, what is the mean distance of the kidney recipients in kilometers to the transplant center?
Well, that study was done in Coventry. It's quite a long time ago, so I'm not sure, but I think that it's not. It's the West Midlands, so it's not going to be a huge distance. It's not like in Scotland or lots of more spread out areas in Europe. So I would think it's going to be under 100 kilometers. But it's true that transplant patients do travel quite far because their care is in tertiary centres. So you can have a greater saving from doing a telephone clinic for transplant patients. And also we're generally seen 4 times a year. So you could say see them 3 times online and by telephone, and then 1 time a year, and you'll be saving 3/4 of the travel.
Okay, great, Francis. And I'm afraid we have arrived now to the end of the session, but speakers can keep answering the questions in the chat that were not answered, because there are still some really interesting questions to be answered in the chat. So I really encourage speakers to go back to the chat in Swapcard, and everyone to keep the conversation going during the conference. And just before we leave, I would like to thank you, especially our speakers, but also the audience for participating in this session. And I would like to highlight another session of the same track of the conference. This session, it's called Transforming Clinical Care Through Research and Practice, and will take place next Wednesday at 10:30. And I hope that you join this and other sessions. Thank you so much again, and enjoy the rest of ClinMed Europe. Thank you. Have a great day.